So hi, my name's Jerzy Eisenberg-Guyot, and I'm a postdoc at Columbia. Today I'll be summarizing a paper I wrote with Megan Finsos and Seth Prinz called Dead Labor, Mortality Inequities by Class, Gender, and Race Ethnicity in the United States, which was published in the June 2023 issue of AJPH. So in epidemiology, two main approaches are used to investigate the social causes of health inequities: relational and stratificationist. Researchers using relational approaches analyze health inequities in terms of social relations, like conflicts between groups struggling for power and control over resources. They theorize that inequities arise because the welfare and security of particular groups causally depends on the deprivation of others. In contrast, researchers using stratificationist approaches analyze the social causes of health inequities in terms of differences in inherited or achieved attributes of individuals, like their incomes and educations, rather than in terms of social relations. Stratificationist measures have proven to be powerful predictors of morbidity and mortality. However, by reducing the causes of health inequities to differences in individual level attributes, stratificationist approaches ignore social relations that affect health through pathways other than socioeconomic status, like relations causing stress, and they align the structural factors that produce socioeconomic status and cause inequitable distributions of health-promoting resources like income. Thus, stratificationist approaches are less powerful than relational ones in identifying the root causes of health inequities. In our study, we drew from Eric Olin Wright's neo-Marxist relational theory, which measures class along two primary dimensions: power over labor and productive property in the workplace. The fundamental distinction is between capitalists, those who own productive property and hire labor, and workers, those who own no property and must sell their labor to capitalists for a wage. Under the theory, mechanisms of exploitation and domination link capitalists and workers. Indeed, through exploitation, capitalists appropriate the fruits of workers' labor, and through domination, capitalists exert control over workers' labor activities. In modern societies, however, substantial segments of the workforce occupy contradictory locations between workers and capitalists. For example, most managers lack productive property and must sell their labor to capitalists, but managers control workers' labor and often develop company policy, exercising delegated ownership authority and facing minimal workplace domination. Meanwhile, the petite bourgeoisie, like independent shopkeepers, own productive property, but they do not control workers' labor and instead must labor themselves. The relationship between capitalists, who constitute a minority of the population, and workers, who constitute a large majority, causes health inequities because the wealth of capitalists relates inversely to labor costs and positively to labor effort. That is, the material welfare of capitalists depends upon the deprivation, subjugation, and overexertion of workers. Managers in the petite bourgeoisie often face unique risks in the workplace. For example, although they may operate autonomously, the petite bourgeoisie often lacks sufficient resources to compete with capitalists, causing precarity and stress. Likewise, low-level managers may face exploitation and domination from upper management and hostility from workers below them, inducing stress and other risks. These fundamental class relationships interact with structural sexism and racism to produce health inequities. For example, Black and Hispanic people are segregated into the working class or excluded from the labor force entirely and funneled into especially exploited and dominated occupations within workplaces. Relational theory suggests that the magnitude of class inequities in a given workplace or historical period is shaped by the balance of power between workers and capitalists. And recent trends in factors like labor union density, household income inequities across classes, and growing income inequities in life expectancy suggest capitalist class power is consolidating, which may exacerbate class mortality inequities. Nonetheless, few studies using relational theories have analyzed class mortality inequities in the US, and none have examined changes over time or subgroup differences, a substantial gap given burgeoning mortality disparities across other social axes. Thus, our specific aims in this study were to estimate the magnitude of class mortality inequities among working-age US adults, to analyze changes in such inequities over time, and to identify how the inequities varied across subgroups, including by racialized group and socioeconomic status, which I'll focus on in this presentation. So to address our aims, we use repeated cross-sectional data from the 1986 to 2018 National Health Interview Survey with mortality follow-up through 2019. And we use a cohort study design for our analyses. So nearly 1 million respondents ages 25 to 64 entered our cohort at baseline, which is when we measured our exposure, and they were followed for up to 34 years until they died or reached the end of follow-up. Our exposure was baseline social class, which I'll define on the following slide. Our outcome was all-cause mortality, and our primary confounders included just gender, age, and year, in order to capture the total magnitude of class inequities, including those reflecting the segregation of minoritized and oppressed respondents into more exploited and dominated classes. So to measure social class, we use data on respondents' labor force status, employment status, and most importantly, their business ownership and occupational status as proxies for power over labor and productive property in the workplace, producing classes of incorporated business owners, or IBOs, unincorporated business owners, or UBOs, managers, workers, and those not in the labor force, with IBOs roughly aligning with the capitalist class I described earlier, and UBOs roughly aligning with the petite bourgeoisie class. In secondary analyses, we also subdivided workers into those who were white collar, blue collar, service, or unemployed, subgroups facing varying levels of exploitation and domination at work. So to analyze class mortality inequities, we use inverse probability weighted Kaplan-Meier survival curves. To this end, we first estimated inverse probability weights, or IPW, using multinomial logistic regression. These weights allowed us to construct a weighted pseudo-population in which class was independent of included confounders, by upweighting those with really low probabilities of belonging to their observed class and downweighting those with really high probabilities. Next, we multiplied together the IPW and MPIS sampling weights in order to make our estimates confounder adjusted and nationally representative. Finally, we ran IPW Kaplan-Meier survival curves with robust standard errors, which estimated the probability of survival over follow-up by class and the difference in the probability of survival at the end of follow-up across classes. Now on to some results. First, how large are class mortality inequities overall? So the left panel displays the probability of survival over follow-up by class using our primary measure, while the right panel subdivides workers by occupation and employment status. On the left, we can see that workers and UBOs had a 7 per 100 greater mortality rate than IBOs and managers over follow-up, with mortality risk especially high for blue-collar, service, and unemployed workers, while white-collar workers fared similarly to IBOs and managers. Next, how have class mortality inequities changed over time? So the left panel uses our primary measure, but restricts the 1986 to 1996 waves, while the right panel uses the same measure, but restricts to the 2001 to 2019 waves. In the earlier period, class mortality inequities were small, with workers having a less than 1 per 100 greater mortality rate than IBOs. However, in the later period, workers had an over 3 per 100 greater mortality rate than IBOs, indicating a tripling of the mortality inequity over time, driven by dramatic mortality rate decreases among IBOs and their managerial counterparts, and stagnant or increasing mortality rates among workers and UBOs. Finally, how do class mortality inequities vary by racialized group in education? So first, the top row displays the class mortality inequities among non-Hispanic white respondents on the left and among non-Hispanic Black, Hispanic, and non-Hispanic other respondents on the right. Unfortunately, cell sizes were just way too small to disaggregate racially minoritized respondents. Nonetheless, we can see the class mortality inequities were smaller among non-Hispanic white respondents than among racially minoritized respondents, driven by excess mortality among minoritized workers and UBOs. Next, the bottom row displays the class mortality inequities among less educated respondents on the left and among more educated respondents on the right. Mirroring the patterns with racial groups, we can see the class inequities were greater among less educated respondents than among more educated respondents, with all less educated classes experiencing greater mortality rates than their more educated counterparts. In summary, using a novel relational social class measure, we estimated considerable class mortality inequities overall. We also estimate the inequities are growing, driven by stagnant or increasing mortality rates among workers, which mirrors trends in socioeconomic mortality inequities. Finally, we estimate greater class inequities among racially minoritized and less educated respondents than among others, perhaps reflecting their segregation into especially precarious segments of the class structure. As a whole, our findings suggest an urgent need for structural interventions aimed at building power among workers and other oppressed groups in the United States. Thanks so much for listening.